Hi everyone.
Hi Dave.
How's everybody? Good to see you all. So tonight our presentation kind of was spur of the moment. We've got some bad news actually. Christy Rector, who is our chapter president, her husband had a serious major stroke. It's been about a week and a half.
Yeah. Yeah. Almost 2.
And they rushed him into the hospital, and while he was at St. Joe's, he had a second occurrence, and then they had to airlift him down to Harborview.
Yes.
And he's down there now, she's down there now, and it looks like they're going to be down there for a while.
3 months.
Yeah. So 3 months was the last ETA. So anyways, and Christy was getting us set up for a presentation with Dr. Casperson. Unfortunately, that didn't quite happen, but we got someone just as good. Maybe even better. This is Melissa Perrin, the famous Melissa Perrin. You've probably heard of her. No, anyway, she and I used to work together at Whatcom Occupational Health, and she moved on to bigger and better things, and she's now with Pacific Northwest Urology Specialist. They have a brand new building that they just built. It's beautiful from the outside, and I'm trying to talk to Melissa into giving me the grand tour on the inside when they're all set up. Anyways, she has agreed to come and do the presentation for us tonight. And she's so nice about it. She even agreed to do it in light of the fact that it's her birthday.
I was tricked.
And so as a special thing, Carol went and got some goodies. Everyone is welcome to help themselves to goodies. There's a veggie tray and cheeses and stuff, and there's a birthday cake. And what do we do when there's a birthday cake? We sing. We sing. So, everyone, happy birthday to you. Happy birthday to you. Happy birthday, dear Melissa. Happy birthday to you.
Best, kind of giving you a quick introduction to urology, but I was more excited to share the things that are at urology that I have never seen before, nor did I know they exist, and most people don't know they exist. So it's just kind of interesting to know what's out there in case you have a patient that has symptoms or something that could be from one of these devices and or equipment, catheters, stents, in your clinic, and at least you would know what they're talking about instead of you have what, where? Then you know what they're referring to. Like Dave said, I work at Urology Specialist. I've been there a little over 3 years now. We have we have 4 doctors, 2 new doctors. This is Resnicek, and the other end is Dr. Roeder. Dr. Casperson and O'Keefe are the owners of this company, and then Natasha is our PA. She's pretty awesome. So we're a busy, busy clinic. I clipped this from our website, not that I was going to read the whole thing to you, but I thought this was kind of cool, and it stands out that last year we seen close to 14,000 patients. Wow. And it is, I don't know if any of you guys know, but we were crammed into an L-shaped hallway in Peace Health while we were waiting for our 10,000 square foot surgery center clinic to be built, which just opened on the 10th of March. Wow. So we've seen quite a few patients, 2,400 of which were new patients, and that was just last year alone. Our surgery center is not quite open yet. I heard probably summer sometime, beginning of summer. Those licenses take longer, imagine that. So I believe once that's open, we'll have like an official community grand opening so that it's not just half open. Everybody can tour the whole building and see what we have to offer. And they just brought in a actual physical therapist that will have a room designated to her for pelvic floor therapy and things like that, instead of sending patients to therapy. Of course they can do that as well, but she'll be right there. They can make their appointments, maybe hop from one room to the next, or pull her in with some questions or maybe enlightenment on what do you think's going on with this patient. So that's kind of cool. Those are some of the new changes that are coming about. And there's the urinary system there. All right. So I'm just going to recap or kind of go over some of the things that we do see patients for. That way when I start showing you these fun devices, you'll know kind of what they're used for and why. So for men's health, we see patients for enlarged prostates, incontinence, frequency or painful urination, kidney cancers, kidney stones, ejaculatory dysfunctions, erectile dysfunctions, hypogonadism, male infertility, men's sexual health, overactive bladder, penile cancer, Peyronie's disease, prostatitis, prostate cancer, testicular testicular pain, torsions, and varicoceles. And with women, obviously, some of the things could be the same, like stones and overactive bladder, but we deal with a lot of recurring infections, prolapse, blood in the urine, birth abnormalities, sometimes with the urethra or labia infusing to the urethra, different cancers, incontinence. Interstitial cystitis is kind of a big one that we deal with. Fistulas, frequency or painful urinations, hydronephrosis, kidney stones, neurogenic bladders we see a lot of, overactive bladder, painful bladder syndrome, pelvic organ prolapses, polycystic kidney disease, urinary retention, urethral diverticulums, mesh complications, and then just voiding symptoms from prolapses. So the first thing I was going to kind of go over are catheters. Have any of you ever had to deal with catheters or know much about the catheters, functions and things like that, personally or in a clinic, or maybe relatives, you've seen it? So there's quite a few different types of catheters. A lot of them are made out of rubber, plastic, silicone, latex. We usually do latex-free. They're silicone coated typically. So the catheter itself could still be latex, but it has a coating over it, so you still have to be kind of cautious, because if you have a patient that doesn't change it regularly, they'll probably break down that layer until they get to the latex, and then they're exposed to their allergy. So urinary catheters are used. A doctor may recommend a catheter if you're unable to control when you urinate, if you're leaking urine, which is the incontinence, or if you are unable to empty your bladder when you need to, which is called retention. If you can urinate a little bit but not fully, it's considered incomplete emptying. The doctors get kind of really upset when you're not using your terms properly, so no urine at all is retention. If they can manage to squeeze them out, they're just incomplete emptying. That's a big thing I had to learn, because to me there was no difference. They're not empty. Reasons you may not be able to empty on your own: blocked urine flow due to bladder or kidney stones. They can get kind of blocked in the urethra. We had a patient the other day that came screaming into the clinic in pain, hunched over. We were thinking prostatitis or something, because he's grabbing down below versus abdominal or something like that. We couldn't get a catheter on his PVR, which is a post-void residual ultrasound we do after someone goes to the bathroom to see how much is left in the bladder. And he had about 1/4 liter, which is okay, but not if he was, in pain. So we tried to put a catheter in, we couldn't get in. We took him into the surgery center in the back, because we can do things back there. And we did a cystoscopy, and he had a pretty big stone stuck right at the entrance of his urethra. So in that case, he couldn't urinate because he had a stone stuck there. Surgeries on the prostate gland. Sometimes the prostate itself prior to procedure is so swollen or enlarged that you cannot urinate. I have a little diagram model thing over here. I'll show you guys what that looks like when you try to enter a catheter and it's enlarged. But typically after a procedure, they'll go home, depending on what the surgery was for a catheter, at least a day, or if it was a full prostatectomy, taking it out, they may have it a week or two. Surgeries in the genital area. A lot of the times, elderly ladies or men that have hip fracture surgeries will come in with catheters. A lot of the time we see them after the catheter is removed, because they're not urinating because of the nature of the surgery and where the surgery was actually at. Spinal cord injuries can happen, giving nerve damage to the bladder. Conditions that impair your mental function, such as like dementia or mental health issues, or medication. There's medications that kind of inhibit your bladder to actually do the full function of not only squeezing, but squeezing enough to evacuate all the urine in the bladder. So there are three.
Include like pain medications like ibuprofen and stuff like that?
Yeah, depending on. A lot of antidepressants cause urinary symptoms.
And I remember when I was taking pain medication, my intestinal tract was all messed up. So I don't think they can do the same with the urinary tract.
Yeah, it causes constipation, and you would probably see that sooner in a male than a female, not the constipation part, but the inability to empty fully because you become constipated, and then the pressure of your stool pressures on the prostate, which presses, it's like a chain reaction, everything just gets shifted up a little bit, and then it's just kind of harder to pass anything you're trying to pass, stool or urine. So that definitely can, but we see a lot of people on antidepressants that we tell them to taper off if they can. Yeah.
So my daughter, she went in for to go peeing herself. She was 8, and they said she was so constipated that she couldn't. She didn't know she had to pee, and it would just allow. So it's different than a male, where it can just allow.
In children, we see that a lot lately. Our doctors are on a big kick right now to check the bowels first, and we do a Miralax clean out, but you make more urine at rest, and then you're relaxed at rest too. So if she was she wetting at night, is that what you said?
No, none at night. It was during the day.
Yeah.
When she was out playing and just sitting at school, and she just peed.
Yeah. Yeah, we see that a lot too, but more so kids, that were potty trained and then just started wetting the bed again. Okay. So if you didn't catch it in time, it may have rolled over into nighttime wetting. So yeah, it's becoming a big thing in the way people eat and all of that. They just backtrack it to all of that. But we're seeing a lot where there's specialties with peds too, pediatrics. So we're starting to see a lot more children with that issue alone. Yeah. So there are 3 types of catheters. There's an indwelling catheter, which can be either a urethral or a suprapubic. So urethral, obviously, into the urethra, but a suprapubic tube is placed kind of above the pelvic bone, below the belly button. Usually people that are long-term, wheelchair-bound type of patients, it's always recommended to do a suprapubic tube for multiple reasons, less chance of infection, and they're not getting pulled on it when they're doing transfers and things like that. And then we have external condom catheters. So these condom catheters go on just like a condom. This end rolls down onto the head of the penis. It works if you're circumcised or not. It just might be tricky to get on somebody if they're not circumcised. You'd want to retract the skin, and then this just plugs into a bag.
Want me to pass it around?
If you want to.
He would love to.
And then there's the short term, what we call the intermittent catheters. So those are straight catheters. They just go in and out of the bladder to drain. They go in enough. These have little holes at the end. They don't have a balloon like these last catheters. How do I go back? Like these last catheters here, you see they have a little balloon. And I'll show you guys up here with the diagram. A balloon that holds it in place so it can't pull out. And the straight catheters is for somebody who, maybe they have a neurogenic bladder. They know they don't empty, but they don't want to live on a catheter. So they just empty sometimes 1, 2, up to 6 times a day. Usually we start people off with emptying in the morning when you wake up and then before you go to bed, so that they don't have old urine hanging out, which causes infections. Different types of incontinence is stress urinary incontinence. So that's developed from weak pelvic muscles, lets urine escape out of the bladder. Stress urinary incontinence happens when the pelvic floor muscles have stretched. Physical activity puts pressure on the bladder, then the bladder leaks. Leaking may happen with exercise, walking, bending, lifting, or even sneezing and coughing. It can be a few drops of urine to a few tablespoons or more. And medically speaking, stress urinary incontinence has to be rated. We have guidelines in the specialty. We have to rate all of the conditions we see, and they can only be rated in a mild, moderate, or a severe manner. Overactive bladder. With overactive bladder, your brain tells your bladder to empty even when it isn't full, or the bladder muscles are too active. They contract, squeeze to pass the urine before your bladder is full. This causes the urge or the need to urinate. The main symptom of OAB is sudden urge to urinate. You can't control or ignore the gotta go feeling. It's just that constant gotta go, gotta go, gotta go. Mixed incontinence is when you have a little bit of both. And then overflow is usually not necessary. Well, it can happen if somebody's in retention and they don't know it. We see this in the clinic a lot. Men don't come to the clinic as often as females, let alone the generation that's dealing with BPH or urinary symptoms. They are just not educated enough to understand, I'm not peeing. They might say, oh, I just had this abdominal pressure and now I'm leaking a little bit every once in a while. What happened is their bladder's gotten so full that it's just letting that little bit out. It's like filling up a bucket and just the top rim just dribbles out all the time. So that's some parts of overflow incontinence. Some other ways could just be the bladder doesn't function properly, and it does that overactive bladder quiver, you know, and then you've got little dribbles that end up leaking out.
Okay,
Yeah.
on an overactive bladder, on TV, on the commercials, you
Uh-huh.
see it as a woman.
Uh-huh.
I mean, okay, but are there men that also have that all of a sudden? I mean, there is no, if it's time, it's time.
Urgency.
Yeah.
Thank you.
Urgency, frequency. Yeah, there's a whole AUA symptom score we do on men to determine if it's the prostate symptoms, LUTS. We call it LUTS, lower urinary tract symptoms.
Okay.
So we kind of go through the scoring process with men a little more than we would with women, because it's kind of hard to pull that info out and to know, are they having a dysfunction of the bladder or is the prostate the cause? We do have a test called urodynamic studies, and it's an hour-long test. The CMAs do it, or at least I do. I was trained to do it. And it's just you and the patient that day, and you put a catheter into the bladder and one into the rectum, and you slowly fill up their bladder, and you can get to the bottom. What you're trying to do is recreate one of these symptoms.
Okay.
And sometimes someone might come in thinking they have stress incontinence because they get up to go to the bathroom, but they leak getting up. Well, in my test, I do coughs and pushes and try to get those instances to happen. I tell them, this test is like your lawyer, let's prove your case. And it's urge. You will see the bladder pressure rise, the detrusor muscle, which is your bladder muscle, pressure rise, and then a leak happens. So we are able to determine if you have one or the other or both. That way they can treat you appropriately. Just like men with enlarged prostates, we'll put them through that test if they're thinking about doing a surgery, because yeah, we can still work on your prostate, but what's really the point if your bladder doesn't function, if you don't have that detrusor incline showing that it's trying to work and squeeze the urine out. So it's kind of just a marker, or a neurogenic bladder. Sometimes that line lays flat, and then maybe if I do the test tomorrow, it might spike a little. So it's just, they're hard to track. So there's different ways we can try to get to the bottom of it. So ultimately, this treatment doesn't treat that and vice versa. These have to be treated separately. Yeah. I don't know, can you see that poster? I kind of put these on here. So urge, you see it's kind of like a quivery bladder sensation. Stress is when you've got pressure from the outside going in. So if you're coughing, pushing, picking up heavy stuff. And then overflow is like the pressure within. So it's kind of an easier way to keep track of that. For stress urinary incontinence, there are no FDA-approved medicines to treat stress yet, but there are things you can do, ways to manage, like Kegels, exercises to strengthen pelvic floors, lifestyle changes, vaginal and urethral devices, pads. Some surgeries, you could have stress incontinence from prolapse or something, and so you got weak muscles, so a bladder neck sling might help, things like that. those are other reasons why they would put you through urodynamics, is to see what indeed is going on with your incontinence, what kind do you have. Overactive bladder is more likely in men with prostate problems and in women after menopause. It is caused by many things. Even diet can affect overactive bladder. There are a number of treatments. They include lifestyle changes, drugs that relax the bladder muscle, or surgery. And if you have both, they do treat them separately. We do a lot of bladder Botox, for overactive bladder, urge incontinence. And what it does, just like relaxing the wrinkles up here, it relaxes the bladder, not numb it or anything, but enough to where when it does that overactive squeeze, it's not so intense. And if it doesn't fix somebody's incontinence altogether, it at least buys them that extra time to get to the bathroom so that they can urinate. Especially poor elderly women or men, by the time they get up in their walker and get moving, they've already wet themselves. So it gives them that time they need.
So for the Botox for that type of a treatment, is it the similar longevity as for a cosmetic for 3 to 4 months, or do they get a longer?
Yeah, but we do 100 units.
Okay, so you're doing a
baseline.
larger
You guys do
dose.
like 13 or.
Well, it depends
25,
on the
35.
cosmetic or if we're treating medical things as well.
Yeah.
Starter
Starter dose is 100.
Okay, and how long would that last for them? probably?
Lately, we've been seeing people for almost a year, but
Oh
it
my
also
goodness,
depends
wow.
on what their underlying issue is for it. So I have a lady that's kind of paralyzed on her left side from a stroke, and she comes in every 3 months
Okay.
with a 200 dose because she's got other underlying issues. So her bladder symptoms go urge, then they go frequent, then they go stress leaks. So it's like we're just trying to help her from every side. She likes to go on lots of vacations, and she wants a dry week for her Cancun trip. So we get it, and she likes it while it works. And then we have some ladies that simply this is all they're dealing with down there, and it can last a whole year. I think 2 months is when we can repeat it.
Okay.
Just because of the toxin, right?
Right.
You can't just repeat stuff like that.
Very interesting.
But we go into the bladder with a cystoscope, and we feed a teeny little needle through it. That's like, it looks like the size of a bee stinger, maybe double a bee stinger, but it's pretty small. Prior to that, we use a straight catheter and instill just straight lidocaine, a whole bottle of lidocaine in there, and let them sit for about 10 minutes. No, it doesn't numb up anything but the bladder wall. They'll still feel the feeling to urinate and things like that. It probably 10 minutes to let it kick in, 5 minutes for the procedure, and they're out the door.
That's so interesting.
Yeah,